Hello, everyone. Welcome to our latest edition of the AAP section of Neonatal-Perinatal Medicine Journal Club webinar. Today, it's a real pleasure to have Dr. Roger Faix from University of Utah, one of the most prominent expert on the hypothermia trials and neurodevelopmental outcome preterm infants. And joining us all the way from Australia, Dr. Atul Malhotra, another prominent expert in neonatal neurodevelopment, joining us to provide their insight and a lot of learning points for many learners in the audience here. And we have Dr. Zayna Bakizada, who is a fellow at Children's Hospital of Colorado. She has made some excellent presentation slides, so I'm very looking forward for this fruitful presentation today. So today's topic is going to be the whole body hypothermia for neonatal encephalopathy in preterm infants. And we get to hear it from the man himself, Dr. Roger Faix, about this trial. And I welcome all of you who, despite being so late, showing up for this webinar. As just for housekeeping stuff, if you have any questions for this presentation, please put it in the chat. We'll address it at the end of the trial and try to tackle the questions one by one. With that, I'll have Dr. Wolf introduce Dr. Roger Faix for us.
Great. Welcome, everyone. It's my pleasure today to introduce Dr. Roger Faix. He's a professor in the Division of Neonatology at the University of Utah School of Medicine. He provides neonatology services in the Neonatal Intensive Care Unit at the University of Utah Hospital, Primary Children's Hospital, and Intermountain Medical Center. Dr. Faix has a longstanding interest in clinical aspects of neonatal, perinatal, and nosocomial infectious diseases. He was the PI for the Utah Center of the NICHD Neonatal Research Network and has devoted much of his research career to the implementation and design of clinical trials in high-risk newborns, addressing prevention and amelioration of chronic lung disease, retinopathy of prematurity, hypoxic ischemic brain injury, and necrotizing enterocolitis. He's also actively involved in development of protocols and practice for prevention of nosocomial infection in the NICU. And finally, he's the first author of the article for our journal club today, Whole Body Hypothermia for Neonatal Encephalopathy in Preterm Infants. Welcome.
Thank you.
With that, it's my pleasure to introduce Dr. Atul Malhotra, who's a senior neonatologist at Monash Children's Hospital and an academician in the Department of Pediatrics at Monash University. His clinical research interest focuses on improving respiratory and neurological outcomes of high-risk infants. He's also a translational and a basic science researcher who's interested in understanding and treating brain injury related to high-risk perinatal conditions such as HIE. He has been instrumental in translation of various preclinical therapies from the lab to the clinic, including regenerative cell therapies. He's the co-director of the newborn cell therapy group at the School of Clinical Science at Monash Health, and has also led the world's first in-human trial of placental stem cells and cord blood-derived cells in preterm infants. He is a passionate Australian. He's passionate about education and serves as the inaugural co-chair of Monash Children's Hospital Simulation Center. He has a keen interest in neonatal evidence-based medicine and is passionate about neurodevelopmental follow-up high-risk births. So he's one of the perfect mentor to help us with this trial. With that, I'll have Dr. Bakizada take over the presentation.
Thank you. Let me pull up my slides. All right. Well, thank you for that and for the opportunity to present this paper to you all today and prepare us for what I hope will be an interesting discussion. My name is Zayna Bakizada. I'm a second-year neonatal perinatal medicine fellow at the University of Colorado and Children's Hospital of Colorado. And I have no disclosures. So today I will first spend time reviewing some background on HIE, including the pathophysiology. I'll give an overview of what was in the existing literature on this topic when the study was initially conducted to help add context to the study question and design. And we'll review the study design and evaluate its internal validity before I highlight the key results so that we can have a discussion on their potential impacts on clinical practice. Hypoxic ischemic injury is the most common cause of encephalopathy in neonates, also called HIE. It affects 1 to 3 per 1,000 live births in developed countries. And despite advances in neonatal healthcare, about a quarter of all neonatal deaths are due to HIE, and 30% of survivors of neonatal hypoxic ischemic brain damage develop disabilities, including cerebral palsy, seizures, and cognitive and memory impairment. For myself personally, in my short time in the field so far, HIE has been one of the most devastating, but also quite variable diagnoses that I've seen in the NICU. To review the hypothesized pathophysiology of HIE, I've included this image from Dr. Titoru. The disease process evolves over days via 3 consecutive phases: primary, secondary, and tertiary energy failure. First, you have the hypoxic ischemic insult, where there is decreased oxygen delivery to the brain. And immediately after the hypoxic ischemic insult, the lack of oxygen and glucose reduces mitochondrial phosphorylation and ATP availability, leading to anaerobic respiration. We see extracellular acidosis that interferes with ionic pump function, so calcium influxes into the cells and the cell releases high concentrations of glutamate. This glutamate contributes to an excitooxidative cascade, triggering neuron death and necrosis. Next, when oxygen is reintroduced, there is a latent recovery phase. Here, aerobic respiration resumes and there is homeostasis. However, depending on the severity of the original insult, the primary energy failure might not be fully compensated, leading to secondary energy failure. This phase starts as early as 6 to 12 hours after the initial hypoxic injury. We see continued excitotoxicity with calcium influx, oxidative stress from mitochondrial impairment, and inflammation that enhances free radical formation and cell death. Depending on the duration and severity of hypoxemia, tertiary energy failure can occur in the subsequent days and persist for weeks and months. This involves remodeling and repair, astrogliosis, as well as some late cell death. The latent period is the targeted period for the therapeutic window in HIE, because at this time, active cell death pathways can lead to secondary and eventually tertiary energy failures. So at this point, one can interrupt this timeline of disease by fighting the onset of secondary energy failure. During therapeutic hypothermia, the patient's temperature is lowered from 36 to 33.5 degrees Celsius and continuing to cool for 12 to 72 hours in order to reduce cell metabolism and energy requirements and counteract an event of energy drop. It was studied extensively in animal models before clinical application in humans. So prior to therapeutic hypothermia, also commonly referred to as cooling, there was no specific therapy for perinatal HIE other than supportive measures. The combined mortality and long-term neurodevelopmental impairment rates were approximately 60%. The larger clinical trials of therapeutic hypothermia in HIE were published in the 2000s. Here, I highlight a few of the landmark trials. Each of these were powered to detect a difference in the primary composite outcome of death or disability at 18 to 24 months of age. They all showed a benefit from cooling. A published meta-analysis that included these large clinical trials demonstrated a reduction in relative risk of the composite outcome by 24%. The CoolCap trial was conducted in 25 international centers. This trial, published by Dr. Gluckman and colleagues in The Lancet in 2005, used selective head cooling as the intervention. Then the NICHD Neonatal Research Network trial, published in the New England Journal of Medicine, tested whole body cooling using Blanketrol cooling blankets. And finally, the Toby trial came out of England in 2009, further adding to the evidence for whole body cooling. While all three of these studies had slightly different inclusion criteria, they all required infants to be at least 36 weeks gestation to be eligible for therapeutic hypothermia. And then in 2011, Dr. Jacobs and the Infant Cooling Evaluation Collaboration published the ICE trial, which was among the first to publish safety and efficacy data on therapeutic hypothermia that also included newborns of 35 weeks gestation. Of note, the number of 35 weeks gestation infants in these studies is not in the original papers, but reportedly, based on conversations with the investigators, that there were 2 randomized to control and 5 cooled, so 7 in that group. Given the evidence above, the American Academy of Pediatrics' current recommendation is to offer therapeutic hypothermia to infants born at or greater than 35 weeks of gestation. The 2013 Cochrane review of the original cooling trials pointed out that further well-designed and executed studies with appropriate power were required to better understand the optimal way to deliver therapy. This included investigating different cooling modalities, durations, target temperatures, and initiation time. The Cochrane review also pointed out that there are other populations not included in the original studies in which therapeutic hypothermia may benefit, and further study was needed to evaluate the safety and efficacy in these populations. This included those with mild HIE, infants on ECMO support, and those with mild hyperammonemia. And finally, the Cochrane review mentioned the population that is studied in the paper we're discussing today. Could therapeutic hypothermia be used to treat HIE in premature infants, a population that, as our field knows too well, is already at risk for adverse neurologic outcomes due to their lower gestational age? I wanted to mention that prior to the study we're discussing today, there had already been practice creep of therapeutic hypothermia in younger gestational ages than the original RCTs. Dr. Shipley and colleagues conducted a retrospective cohort study using the National Neonatal Research Database of units in England and Wales from the years 2011 to 2016. And in addition to identifying neonates with mild HIE who were treated with therapeutic hypothermia, the study also showed that in late preterm infants, gestational ages between 34 and 35 weeks with HIE, 33% received therapeutic hypothermia and 13% died. In this graph, the authors showed the higher mortality in these gestational ages on the left-hand side. One last piece of background information I wanted to review prior to delving deeper into the main paper is the unique pathophysiology of HIE in the preterm brain. Research in animal models has shown us that the severity of injury developed after neonatal hypoxic injury is highly dependent on the timing of the damage in respect to gestation. In preterm infants, less than 32 weeks gestation, hypoxic injury generally has more complex temporal profile with a more chronic nature. It's characterized by cognitive and sensory deficits, and it's thought that the immature immune system potentially promotes an excessive and sustained inflammatory response. We know that in the premature infant's brain, the periventricular white matter is highly susceptible and particularly struck by the insult, resulting in periventricular leukomalacia, or PVL. Pre-oligodendrocytes are also highly susceptible to the pro-inflammatory state and oxidative stress from the hypoxic event, and their death leads to abnormal myelination that's typically seen in MRI scans. And then preterm neurons are also especially vulnerable to the insult because their NMDA receptors are physiologically upregulated and more permeable to calcium, making these cells susceptible to the excitotoxicity cascade we discussed earlier. While all of this supports that hypothermia may help reduce secondary injury in the setting of hypoxic event, there are still possible downsides, especially when we consider how important normothermia has been shown to be in outcomes for premature infants. There was a concern that hypothermia could trigger or exacerbate things like IVH, neck, coagulopathy, or shock in preterm infants, as well as death. Now that we've reviewed some background on the existing literature, I'll direct our attention to the main paper we're discussing today.
So
We already,
I
oh,
think,
sorry.
Zayna, we can, I think, just take a break here and ask Dr. Faix about his thoughts on designing this trial. You presented a really good data on the background. Dr. Faix, can you provide some insight? What was the situation like? Why did you select 33 to 35 weeks gestation, even though the AAP suggested to go beyond 35 weeks? Can you walk through what was going through you while designing this trial so for our learners?
Certainly. We had noted that the AAP recommendation regarding 35 weekers was based on some articles that did not specify the number of 35 weekers nor the outcomes of that subpopulation. In addition, we noted that there were a variety of NICUs in the Intermountain West that through the process of therapeutic creep, we're starting to offer cooling for these less mature babies for whom there was no real evidence about safety or efficacy. So we undertook the trial for that reason. And in all honesty, we had originally hoped that we would just affirm that outcomes were indeed improved at the lower gestational age, as it was in the 36 plus weeks gestation. But we had equipoise and thought the time had come but to address whether or not therapeutic creep was appropriate for this particular population.
Yeah. Thank you, Dr. Faix. Zayna, you can proceed.
Great. All right, so we already have a sense of the population and intervention from the title of the study. Here is the entire PICO. This study looked at infants born at gestational ages of 33, 34, and 35 weeks with HIE. The intervention was therapeutic hypothermia, which was compared to normothermia. The primary outcome was death or disability, either severe or moderate. And the planned assessment time was at 18 to 22 months corrected age. As I reviewed in the background slides, this is an extremely important and relevant research question. And the study, as the study population of preterm infants with HIE has unique physiology that may affect both the benefit and risk profiles of these interventions. And the outcome and assessment timeline are consistent with the previously published RCTs in term infants, which helps add to the existing literature with the same mental framework in mind. To take a closer look at the eligibility criteria, we see that the infants were included up to 35 weeks and 6 days gestation. Other than gestational age, the other inclusion criteria mimicked the ones from the NICHD RCT in term infants. And then I wanted to pause here because the last criteria I have listed, I wanted to ask what the modified SARNAT score looked like, Dr. Faix, and how you developed that.
Yeah, the modified SARNAT score was the same one used in many of the earlier trials. And you can find it in those primary publications that you listed on an earlier slide. It is based on neurologic exam as well as vital signs in 6 different categories. And scoring is classified as either normal, moderately abnormal, or severely abnormal. And in order to qualify, there were you had to attain at least 3 out of the 6 categories being moderately or severely abnormal. If the majority of the abnormalities were severe, then you were categorized as having severe encephalopathy. If the majority of them were moderate, then you were classified as having moderate encephalopathy. One difference I would note compared to the previous trials, because premature babies are different, we required that one of the qualifying abnormalities on the modified SARNAT score had to be an abnormal level of consciousness. That requirement was not required in the 36 plus week gestation group, but we thought it was essential just because premature babies it seemed were so much more likely to have abnormalities in the rest of the exam just because they are premature. For example, tone In term babies, well, 36 weeks and beyond, usually you can objectively assess flexor tone in both the upper and lower extremities. But at less than 36 weeks, the lower extremities usually have assessable tone, but the upper extremities don't. The same is true for posture. So that's a quick and dirty summary of the modified SARNAT score.
Great, thank you. That's really helpful. So exclusion criteria included core temperature of less than 34 degrees, receipt of a paralytic or sedative obscuring the SARNAT examination, encephalopathy that was unlikely due to hypoxic ischemia, major anomalies, and moribund patients not receiving critical care, and a birth weight less than 1,500 grams. And finally, if the clinician decided declined enrollment, the patient was not eligible. I wanted to ask here if there was an issue, at least at our NICU. Most, if not all of our HIE admissions come from other hospitals, and transfers are often delayed due to distance or weather here in Colorado. So we often rely on outside hospitals to passively cool, and then our transport team to cool as well. Was this an issue for you when conducting this trial?
Designing it, we made it clear that we were going to discourage passive cooling, and all the infants had to have a qualifying exam by 6 hours. As it turns out, quite a few of the patients, not surprisingly, were outborn. In my own center, Utah, we have just as much issues with distance as you do, but nonetheless, we discouraged passive cooling. And if you didn't make it to the unit by 6 hours for the exam, then you were not eligible.
Great. So the cooling intervention was done with a Blanketrol, and the target esophageal temperature, or TES, was within half a degree of 33.5 degrees Celsius for 72 hours. The Blanketrol achieves this target temperature by causing a transient decrease in esophageal temperature below the target, followed by warming up to return to the target range. This sequence of events typically happens with the initiation of cooling. However, it's important to note here that the intervention was, of course, unblinded, since blinding providers to cooling status is not typically feasible. And while this is an understandable decision in the study design, it does limit internal validity.
Although would point out that the primary outcome was at least partly based on moderate or severe disability at greater than 18 months corrected age. And the people making those assessments were blinded to the group that the infants were randomized to.
Yeah, that definitely helps compensate for that. So an important component of this study's internal validity is that other than the temperature intervention being tested, both groups were treated the same. An important detail to note, however, is that the control group is not necessarily a lack of intervention. The control group had similar temperature monitoring as the intervention group, and they were servo-controlled by radiant warmer incubator to maintain normothermia, or a temperature between 36.5 and 37.3. And this was done because in prior RCTs, higher core temperatures in non-cooled patients were associated with increased risk of primary outcome, being death or moderate to severe disability. And because of this, steps were incorporated into this protocol to minimize hyperthermia in this group. And that included a tepid sponge bath for hyperthermia. And if that didn't work, cooling with a blanket until target normothermic temperature was achieved. And the primary outcome was the same as that investigated in previous trials in term infants: death or disability, whether it be severe or moderate, at 18 to 22 months corrected age. This is the composite outcome, which is in which multiple endpoints are combined. Composite outcomes are common in RCTs, especially in neonatology, and that's been discussed in prior journal club sessions. The advantage is that it can increase the statistical precision and thus efficiency of a trial. However, it may not always reflect the outcomes that all stakeholders care about, which we can come back to when we discuss the clinical significance of the results. The study used Bayley Scales of Infant Development 3rd edition, gross motor function, classification system level, and vision and hearing status. These are objective and validated measures of neurodevelopmental outcomes that as we know, they're widely used in neonatal research. This study used the 3rd edition of the Bayley, which came out in 2006. At the time of the previous cooling studies in the 2000s, the 2nd edition was used, but they're pretty similar. And importantly, while the intervention was not blinded, as Dr. Faix mentioned, the assessment of this primary outcome was. So blinding of assessors is especially important when there's a subjective outcome, such as symptoms or function. And this is a strength of the study and contributes to its internal validity.
Dr.
Zaina, I
Malhotra,
want
you
to
have a
make a
comment?
I want to make a comment. I'm sure Faix is aware. In term infants, 18 to 22 months, correct age is fine. But in preterm infants, there is very good literature to suggest that 24 to 30 months is the appropriate age. Now, most of the studies which we are involved in is extremely preterm infant. So this group is in the middle. So the term infant 18 to 22 months is fine. For the extreme preterm, 24 to 30 months is probably preferred. In the moderate late preterm infants, it's a bit of a mixed bag, but I think just a learning point for trainees that the assessment done at a slightly later time point is preferable. But I wonder if Roger had a comment, but I'm just making as a learning point.
Yes, in fact, the Neonatal Research Network these days embraces the same guidelines as were just noted. These days, for the extremely preterm kids, they look at 24 to 30 months. We went with 18 to 22 months because that's what had been used in the prior, in most of the prior hypothermia trials that involved kids 36 weeks gestation or greater. So it reflected the practice at the time.
All right, here's the first part of the consort flow diagram for the study, which provided a lot of interesting information. First of all, at the top, you can see that among the 436 infants screened for the study, 135 were excluded based on the study's inclusion criteria. Then there were 82 patients that met inclusion criteria but were not enrolled. This is worth highlighting here that among those, 47 patients weren't enrolled in the study because cooling had already been initiated. This seems to reflect the existing practice creep of therapeutic hypothermia in premature infants. But I wanted to pause here and ask Dr. Faix, were these patients that were already cooled, were they already cooled prior to being screened, or were they screened and then the providers decided to cool any rather than randomize?
Both.
Okay.
At some of the 19 participating sites, there were individuals who did not have equipoise and had their own definite opinions.
Great. All right, the bottom part of the consort diagram gives us helpful information about the quality of the study given the impressive follow-up rate. There was 86% follow-up in the normothermia group and 94% follow-up in the hypothermia group, making overall primary outcome measured in 90% of the patients. However, it's important to keep in mind that more infants were lost to follow-up in the normothermia group compared to the hypothermia group. Additionally, due to restrictions related to the COVID pandemic, some assessments of neurodevelopmental outcome were actually delayed. Seems like based on more recent guidelines, maybe optimal. So the researchers had to use the earliest follow-up date available, meaning the mean corrected age for infants at follow-up was actually 26 months. And this data was still used in analysis as long as the patient's age did not exceed the Bayley examination limit. And unfortunately, that was the case for one infant, and that infant was considered lost to follow-up.
Actually, that 26-month median represented was the median of those infants who were not able to be examined within the 18 to 22 month window.
Oh, okay. Thank you. So in this slide, I assessed the study's internal validity on the by looking at whether the intervention and control groups were similar in baseline characteristics. They do appear to be. They had similar maternal demographic characteristics as shown in the table on the left-hand side. And then on the right-hand side, you can see that they had comparable severity in APGAR scores, as well as acidosis here. And the average age of randomization was the same in both groups. In addition, and I think importantly, both groups had similar breakdown of moderate and severe encephalopathy, so any potential difference in outcomes may not necessarily be due to one group being sicker than the other. Clinical studies on neonates exposed to intrauterine infection report that therapeutic hypothermia does not result in neuroprotection. So I wanted to look closely at the rates of prolonged rupture and choreo in each group. The intervention group had a longer average duration of membrane rupture and higher rate of prolonged rupture, but choreo rates were pretty similar.
Would note that if you look at maternal fever in the two groups, it was quite low in both groups. And fever we classified as anything greater than 37.5. Frequency of maternal fever, whether or not you had prolonged rupture of membranes, was 2% in the hypothermic group, 4% in the normothermic groups. So one might think that pyrexia is at least as important as duration of rupture of membranes. Would also note that the majority of infants in both groups did not have ruptured membranes prior to delivery.
So internally, the two groups of the study were similar in baseline characteristics. However, there were a few characteristics of the study sample as a whole that differed from characteristics of previous cooling trial samples. So for example, maternal hypertension was about 37% and 40% in each group in this trial, which was 2 times higher compared to the study sample in the recent late hypothermia trial, where only 18% had maternal hypertension. Additionally, placental abruption rate was high, 41% and 46%, which was 3 times higher compared to other trials.
So, Dr. Malhotra, this is something what we would anticipate for a preterm trial, right? This preeclampsia is one of the common reasons to have preterm, so it does not threaten the validity of the study.
No, I think absolutely. One of the things which Roger can elaborate on is basically the settings for preterm HIE in some cases might be different to the settings for a baby at term. The problems which you see for a preterm to be delivered might be iatrogenic, if that makes sense, because mom has got indications to deliver a preterm baby earlier, like preeclampsia or maternal indications, while in a term baby, most of the times the settings for HIV might be more placental or baby related, if that makes sense. So there is always that risk that you might have higher risk of maternal and placental problems in the preterm as compared to fetal and placental problems in the term. I wonder whether Roger wants to say, but I think it doesn't change the validity of the trial.
Yep, I agree with your points. Circumstances that give rise to premature delivery are more likely to reflect emergencies that affect principally the mother or the placenta than just baby issues.
Great. Another important component of the study design was the statistical plan. In designing a study, existing data are used to help determine the sample size needed to assess the treatment effect. In the supplement, the authors note that this was challenging here because there was no data regarding the incidence of death or disability after neonatal encephalopathy at the targeted gestational age. So given increased fragility associated with this degree of prematurity, they had to guess that the incidence of death or moderate to severe disability in the control arm was likely to be at least 70%. And then they had to decide the size of the treatment effect they hoped to or expected to detect. what treatment effect size would be clinically significant. To achieve 80% power to detect a decrease from 70% to 50%, they needed a sample size of about 110 subjects per arm. And a decrease from 70 to 55% would also be clinically significant, but since it's a more subtle effect, would require about 190 subjects per arm. So these sample size requirements aren't feasible, particularly in a rare diagnosis such as HIE and prematurity. So the study was designed to randomize 168 babies, which was deemed more attainable based on the recruitment in the previous studies, and analyze data using a Bayesian approach to estimate the effect of hypothermia relative to normothermia, which with as much precision as possible, and allow for a calculation of probability of treatment benefit for hypothermia. While this trial wasn't powered in the traditional sense, they ran several simulations that showed that the trial design had at least 75% chance of observing a treatment benefit. Just a little background on Bayesian statistics. They provide a framework for updating our estimates as new information becomes available. So we begin with a prior probability, which represents our initial belief based on existing data or clinical experience. And then as new evidence is observed, we apply Bayes' theorem to combine that evidence with the prior, yielding a posterior probability, which is our updated estimate.
I just wanted to make a comment here, and I would appreciate Roger's thoughts on this. If you go back to the last slide, Zayna, thank you so much. In this case, you mentioned at the start, Roger, that there was equipoise. Obviously, that's why we're doing the trial. But wasn't there a bit of a enthusiasm that there might be benefit, or you thought neutral prior is the best way to go? I just want to explore that. I think neutral is fine, but was there enthusiasm in the team that it might be beneficial?
Well, we hoped that we would find a benefit, since it would be nice to have something to offer other gestational ages besides just those 36 weeks or greater. But all of those in the network were very accepting that the previously existing data were very sparse and not particularly reassuring. For example, it was already noted in an earlier slide that there were 2 randomized controlled trials actually that included 35 weekers, one of which was mentioned on an earlier slide. And those 2 RCTs, there were a grand total of 7 kids at 35 weeks. 2 of them were randomized to control. 1 died, 1 was a normal survivor, and 5 randomized to cooling. And of those 5, 2 died, 2 survived, but with significant disability, and 1 normal survivor. So no hints that it was going to be beneficial, although in our heart of hearts, we hoped it would be. But that's why you do the studies.
Great. And just to review the benefits of a Bayesian analysis, first of all, as I mentioned in the previous slide, it allows us to incorporate existing data or expert opinion into the analysis, whereas frequentist statistics ignore prior data and start from scratch, which is especially challenging and resource intensive when studying rare conditions. With small sample sizes, frequentist statistics have a higher risk of type 2 error, where you conclude that there's no effect or difference when in fact there is one. Additionally, compared to the p-values reported in a frequency analysis, the results generated from Bayesian statistics are more intuitive because it gives a statement or a probability that a treatment works, as well as a probability that it causes harm. And this can be easier to interpret and apply to clinical decision-making. Finally, Bayesian statistics can be helpful in supporting more adaptive trial designs, whereas frequentist statistics are more rigid or for more rigid study designs. So this brings me to the results of the study we're discussing today. In this graph, you can see the posterior probability for the primary outcome with a neutral prior. You can see that the adjusted relative risk is on the x-axis, and the probability of benefit is in light blue, which includes all probabilities of an adjusted relative risk below or to the left of 1.0. Then to the right in dark blue, you see the probability of harm, or an adjusted relative risk of greater than 1. Visually, you can see that the area under the curve above the relative risk of 1.0 is larger than the area under the curve below, or for benefit. And so the study found that there was a higher probability of harm, 74%, than the probability of any benefit, which was 26%. And probability of death alone was 87%.
This graph, by the way, is just for the primary outcome. A similar graph that was just looking at death for an outcome would be skewed even more to the right side of relative risk of 1.0.
And in the 2017 paper on late cooling, that paper included a version of the posterior probability graph with a region that had near zero, or that had a zone of indifference near the 0 mark. And this illustrated the probability of risk differences where hypothermia and non-cooling may be viewed as equivalent. And many of those authors worked on this study, and I wanted to ask, including you, Dr. Faix, if you guys looked at the zone of indifference here and why it wasn't included in this particular paper.
We didn't look at the zone of indifference because the results speak pretty much for themselves. It's clear that the area under the curve favors normothermia.
Yeah, that makes sense. And then here are the results of the individual outcomes in table format. These posterior probabilities are all using a neutral prior. So as you can see at the top, the intervention group had a 35% rate of the primary outcome, which was greater than 29% in the control group. As I mentioned previously, this is a composite outcome, but when we break it down into its parts, the mortality data is interesting. The intervention group had a 22% rate of mortality, while the normothermia group only had 13% mortality. And when it came to mortality, the posterior probability of benefit was only 13%. Lower down in this table, you can see that the probability of benefit was pretty similar in infants with moderate HIE diagnoses as it was for the severe category. To get a little bit more into the results, we can turn to the supplements attached to the paper. Stratification by gestational age and exploratory analysis revealed higher incidence of primary outcome in hypothermic infants within each gestational age group, and of death at each gestational age except for 33 weeks. However, it's important to point out here that the authors did not conduct any formal hypothesis testing on these subgroups, so we can't say whether these differences are causal or due to chance.
Agreed, and would point out that we did not start out with the idea of reporting stratification by gestational age, but there were so many questions related to that when we presented at national and international research meetings, as well as by the journal reviewers, that we added the table, even though our initial intent had not been to try to break things down by gestational age.
So previously I mentioned concerns that therapeutic hypothermia might trigger or increase risk of complications of prematurity, such as IVH and neck and coagulopathy. Though the study was not powered necessarily to detect a difference in these adverse events, the table here helps give us an idea of how the two groups compared. Overall, we see that the most of the adverse events had a posterior adjusted relative risk that included the null value of 1, thus finding no statistically significant difference between the groups. I highlighted here that this includes IVH, major bleeding, and thrombocytopenia. Since there were no cases of thrombosis or neck in the sample, the study is unable to estimate the relative risks of these adverse events, and also none of the infants required ECMO. When taking a look at the bigger picture for the entire hospitalization, there was no difference in length of stay between the groups, despite the hypothermia group having a median 1.5 more days of mechanical ventilation. This was the only adverse event that had statistically significant difference between the groups, but given the small risk difference and lack of difference in hospital stay, this finding doesn't seem clinically significant. Some interesting results included the frequency of temperature overshoot in the intervention group. Out of 88 infants in that group, 32 were reported to be out of the target temperature range at some point. And the authors mentioned that the observation that many infants randomized to this group had low temperatures is not surprising, since preterm infants are in general more likely to have difficulties with thermoregulation. However, this could potentially indicate that these babies were potentially sicker or at higher risk of adverse outcomes. And then I didn't know or think much about the different types of cooling before preparing for this presentation, but I included this slide because of the reported issues with temperature overshoot. Newer generations of whole body cooling devices are reported to have reduced likelihood of overshoot. So the Blanketrol used in this study uses water circulating technology, while the other cooling technologies like the Arctic Sun use gel-coated adhesive pads. And there's a recent, though very small, trial of 66 infants published in 2024 that compared the two. And in that study, both methods achieved the same median temperature of 33.5. However, the Arctic Sun showed less temperature variability compared to the Blanketrol system and was strongly preferred by nurses, who cited its ease of use and less need for manual intervention. So while this was a small study, I thought it was interesting whether Dr. Faix, do you think that the device used or the cooling technology affected things? And I have the results for the omitting the the overshoot babies as well.
So first, this table illustrates if you exclude all the kids who did have temperature overshoot in the hypothermia arm, these are the results. And while there's not necessarily any evidence of harm, particularly death, there really isn't any evidence of benefit either. With respect to your question about whether newer generations of cooling devices might offer advantages with respect to avoiding overshoot, I can't really address that. It's distinctly possible, but I will note that we're further analyzing our data, just looking at the hypothermia group, comparing those who did have significant overshoot, 32 degrees or less, versus those who didn't. And in fact, there's striking evidence that those that did attain a temperature less than 32 during the intervention period had probably sustained greater insult at the time of randomization. They were much more likely to have severe encephalopathy, lower APGARs, more notable base deficit, more likely to require chest compressions, resuscitation medications. So I can't tell you that the overshoot had anything to do with the outcome. In fact, being more depressed at birth may set you up not only for adverse outcomes, but a greater likelihood that you're going to have overshoot to begin with.
Great, thank you.
Roger Faix, another question. Did you do neuroimaging for all these babies, and do you have
We
any?
did, and as indicated in the primary manuscript, those are to be reported separately. Similarly, while EEG recordings were not required for entry, the vast majority of the kids did undergo continuous EEG monitoring during the intervention period, and those will also be reported separately. The results of the imaging studies were reported preliminarily at this year's PAS meeting, and manuscript regarding that is being worked on currently.
So a lot more to come still.
Stay tuned.
Yes.
All right, so to summarize, in this presentation, we discussed a study that addresses a very important PICO question that's relevant to clinical practice, especially in the setting of existing practice creep. And the study design, while there were some unavoidable factors that limited internal validity slightly, such as not being able to blind an intervention such as cooling, was otherwise very strong. External validity or generalizability could have been affected, but it sounds like the maternal baseline characteristics are actually pretty consistent with what you would expect in a preterm population. So it still reflects the population that we are curious about. And then the Bayesian statistic statistical analysis method chosen helped generate informative results on a clinically relevant outcome despite a moderate sample size. So this study found that when initiated in infants 33 to 35 weeks gestation with moderate to severe HIE, therapeutic hypothermia did not reduce the primary outcome of death or moderate to severe disability or death alone at 18 or more months. And then there was a 74% probability of treatment harm for the primary outcome, as well as an 87% for death alone with hypothermia. There also seemed to be no clinically significant difference in adverse events. And while there were issues with the protocol in that there was temperature overshoot or overcooling in the intervention group, which may have affected results, but doesn't seem to affect the composite primary outcome necessarily.
One thing I would point out with respect to the overshoot, in fact, frequency of overshoot in our study was lower than that in several of the earlier trials that were limited to kids 36 weeks gestation and greater. Although benefit was demonstrated in those 36 weeks or greater.
So some other, as my final slide, just questions or thoughts for discussion. Is this trial of 160 infants enough to change our clinical practice now? The adverse events would be better estimated potentially if there was a larger sample size or if multiple studies were compiled in a systematic review. However, that's probably more challenging after this study, given that no effect was necessarily found. And then finally, how should we discuss this with families? How might they feel about these results? And what does informed consent look like for if we continue to cool premature infants? Just some questions I wanted to open up to the group.
So while we open up the discussion for the audience members, I'm just going to run a quick poll for our members and can take the discussion from there. With that, Dr. Malhotra, question for you. I mean, it is very commonly asked that there has to be stratification according to gestational age. Now, what are your thoughts based on the results of the study and how difficult it is to have adequate sample size to get results for the study, and how should that inform our practices about these 35-weekers or 34-weekers?
Yeah, I think Roger has covered this to some degree. So one of the problems in babies between 33 and 35 weeks is that the population is a very small population of babies who actually suffer significant perinatal event leading to HIE. So I think the group was right in not trying to stratify it according to gestation because they were already struggling with numbers, and Roger can attest to that. It took them around 7 years, is that right? Or more than 7 years to recruit to this trial. If they
A
stratified
little
it,
over, yeah, a little over 5 years for recruitment and then 2 years of follow-up.
yeah, 2 years for follow-up. Yep,
And
yep.
that was with 19
Yes.
relatively large centers.
Yeah. So coming back to your question, Viral, the problem is this population is not a population where a significant sentinel event is going to be common, which is good for the babies and families, obviously. So trying to recruit according to stratifying for gestation would mean a much longer trial. The Bayesian stats helps in trying to reduce the numbers to some degree, but as you know, it doesn't reduce it completely. So I am with the team that stratifying according to gestation is really hard. And if someone wants to replicate this trial with stratifying to gestation, it is going to be a big task. It's going to be a huge task. So it's unfortunate that we don't have a subgroup analysis because the numbers are small and it wasn't pre-specified. But I absolutely agree with the authors that this is probably the best way to do it.
Yeah, I mean, and if you take a frequentist approach, the amount of sample size required to get answer for this question is going to be, it's going to take someone's lifetime to get it there. I'll just quickly share the results of the poll. So before this trial, it was very common to cool up to 35 weeks gestation, and probably has a lot to do with the AAP guidelines saying to cool for more than 35 weeks, even though there were only, like Dr. Faix pointed out, 7 babies included in total studies and only one had good outcome. However, in spite of the results of the trial, people have not changed. About 67% still does not want to change their cooling protocols at this point, and still about half of them still limiting, half of at least limiting to 36, and the rest are still doing it below 36 weeks in spite of the results of the trial. So not sure, Dr. Malhotra, do you have any insight where the future trialist in this audience should look for to find the answer, whether it's safe to cool? I mean, these results are pretty convincing. The Bayesian analysis is pretty robust to say that it is harmful for those 30 to 35 weeks. Yeah, we don't clearly know 35 weeks, but we may never know the answer. So should we follow the latest evidence-based medicine, or how we approach this subject to change the
So I'll
mind of the audience?
Yeah, I'll answer it in two parts. First, I'll answer it from a Victorian standpoint in Australia. So Victoria is the state which Melbourne is in. Once the trial was published, we obviously knew the results before the trial was published, but we wanted to wait for the publication. Sita Sankran kindly joined our discussions in Melbourne about the trial. We had very good support because we were part of the, you can say, ICE trial background in Australia. Our guidelines were also to cool over 35 weeks. And since this discussions and this study being published, we have changed our state policy to take the 35-weeker baby with perinatal HIE, moderate to severe perinatal HIE on a case-by-case basis. So it is not a strong or a blanket no, but we have changed it from basically doing it for everyone over 35 weeks to doing it for everyone over 36 weeks, and the 35 weeks becomes a case-by-case basis. I'll put in the chat a publication led by the Newborn Brain Society and they surveyed a lot of centers across the world, including the US, of their practices. And I think the feeling is still that it's a bit of an equipoise. People haven't committed to completely stopping cooling at 35 weeks, but 34 weeks, as far as I know, almost every center I know of is planning to or is stopped cooling at 34 weeks. But I might be wrong. But 35 weeks is a bit on the fence still, unfortunately.
Yeah. And Dr. Faix, so I mean, your results are pretty clear cut. So do you think that will convince the AAP to drop down from 35 to 36 week again? I ask because there's a lot of medical legal implications too.
There
We need
is
more.
apparently a new AAP statement that, if it hasn't been published yet, will be very, very shortly.
Mhm.
And they have recommended its routine application down to 36 weeks, and 35 is very similar to, sounds like what our Australian colleagues, at least in the Victoria state, are doing, in that they recommend a thoughtful discussion with parents at 35 weeks gestation and very careful attention to informed consent.
Yeah. With that, so Dr. Malhotra, there's a question from audience for you. So could you classify what those 35 weeker case by case criteria would be if someone in the audience wants to cool?
I hope I don't need to face that myself because it's a really hard one. I think the situation will be, a 35 plus 5, 35 plus 6 weaker gestation baby who's got a very robust birth weight of, let's say, 3 kilos, or, those kind of ones where the gestation, it's almost like the 21 plus 5 to 22 weaker kind of discussion when we have for resuscitating at extreme viability. I think that is the discussion. I personally feel if it's a 35-1 gestation baby, I personally would discuss with the family that I'm not really convinced. Having said that, I've been in practice for almost 25 years. I've not pulled many 35 weekers, so it's not a common incidence. That's the issue. I think it's not a very common incidence that we have to consider them. But yeah, I'm going to take it with a very thoughtful approach to it and discuss it with the family. But I think I'm erring on the side of the bigger, more mature baby.
Yeah. Well, I think we are almost right on time. Dr.
May I make
Yeah.
one additional comment?
Yeah,
And
sure,
that
Dr.
is
Faix.
just
Yeah.
to point out that
Yeah.
Bayesian analysis may be helpful in that it does permit using this existing data to be lumped together with any new data that emerges about kids at 35 weeks gestation, 34, 33. And you can reanalyze and redetermine what the probability of benefit and harm is. So one of the advantages of Bayesian is that you can use accumulating data from different trials. While that does come with its own set of limitations, it is one thing to keep in mind as further data is gradually accumulated.
Yeah. I think almost time, but any other final closing comments from you, Dr. Malhotra, Dr. Faix?
I first proposed this study in 2011, and it finally is published in 2025. So it frequently takes a while, and quite a bit of resources, education, communication to conduct a trial such as this.
Yeah, and it's splendid for all the learners to in the audience too. It's an important question. An important question sometimes takes a long time to get the answers, but the results are pretty convincing. And no matter how you argue, the results are results, and certainly give us some way forward on how to cool the preemie infants. With that, I'd like to thank every one of you for joining this call today. I know it's very, very late and you still guys showed up, so that's very nice to see. And for obviously this recording will be available for other listeners who could not attend due to timing issues on the AAP website. With that, thank you so much for all of you attending. Dr. Bakizada, it was an excellent presentation, very well laid out. Dr. Faix, thank you so much for your insight and serving an inspiration for all our learners, and Dr. Malhotra for your wonderful insight as always on the evidence-based medicine of the study. Thank you so much. I'll see you all again next month.
Thank you very much.
Thank you.